Thanks. Thanks for having us. I like this debate. I'm just going to jump into it, but I'm not going to be as didactic because we're doing like these case presentations. But I was really focusing on more melasma because I think that's one of the most common things that we see. And you could go either way. Like the literature shows that you can use both peels and lasers. However, it's a multimodality approach, and I think in reality we're using a lot of things to just treat this one specific disease. But I like Nolani's approach. Like if you don't have a laser, it doesn't matter. You can use peels very effectively. But not everything's melasma. So as always, we should be looking at like a difference in diagnosis. And you know, Hori's nevus are very typical in like the Asian population, so you should think about that. Obviously, we know melasma. We'll talk about like a little clue that we can use to diagnose that. But then there's also lichen planus pigmentosus. We see it in darker phototypes. It very light responsive. So right, if they have any history of like a lupus or some photosensitizing disorder, you really want to get the knowledge ahead of time, right, before you start these patients on any other treatments that may be more photosensitizing. So melasma really is just mainly a clinical diagnosis, but you want to make sure you're not missing something. But this classic appearance of melasma is this sort of like cobblestone pattern. There's confetti-like macules, but there's really like intervening areas of normal skin, right? Their normal skin tone is like peeking through this hyperpigmented patch. And we know all these triggers, but we need to think about the less obvious ones like thyroid abnormalities and contact dermatitis, right? So your patients may be trying all these home remedies, and now with TikTok and like everything that's on the internet, they're like, you know, putting lemon juice on their face, and lemons and limes are also photosensitizing. So people are doing like wild things at home. So I always try to like just get to the bottom of things as quickly as possible. But of course, common triggers are the like oral contraceptive use, pregnancy, and then just UV visible light, but also heat. Like heat is a known trigger, and that's why, you know, being careful with lasers and how much heat you actually induce onto the skin is really important. So obviously you can just look at the skin, but if you have any sort of instrumentation in your practice, try to use it. So a Woods lamp is like really helpful. So we're just going back to basics, right? You can just accentuate the contrast. Also, patients love to see this, right? They don't have a Woods lamp at home, but if you have a Woods lamp, the melasma appears darker. And Woods lamp highlights epidermal melasma more so than dermal melasma, but that's not always the case. But for the most part, you can try to tell the difference between epidermal, superficial melasma, and deep dermal melasma. But normally it's a combination of both. Dermoscopy is also helpful, and then I'll just like talk about confocal microscopy because we're at a laser conference. But dermoscopy, it's cheap, and if you have the dermoscope, you should try to use it because it would give you a little bit more evidence, right? So this is just a typical pattern, bilateral on the cheeks. If you look at the dermoscopy, not only will you see the pigment around all these like follicular openings, but you'll see how much vasculature is there. And that's where I think dermoscopy comes in handy, because we know now that there's a vascular component to melasma and to this pigmentation. So if you put the skin on stretch and then use the dermatoscope, but don't blanch the tissue, right? Because then you'll lose the vasculature. But if you just take a quick look with your dermatoscope, you can see these these vessels that would blanch and they're branching. And that's a clue that you can use a vascular laser to treat melasma. And so, or treat a component of the melasma. So it's really important. And it could be maybe why tranexamic acid works. We're not really sure, right? But like that helps in reality. But if we just look at this patient that I showed you and we go on dermoscopy, we don't see those blood vessels, right? So for me, this tells me that, okay, I'm not gonna like even waste my time with a vascular laser because it's not gonna improve anything, right? So it's really just this epidermal pigment that's there. So when pigment is concentrated in the lower parts of the epidermis, then dermoscopy reveals a lighter brown colored network. So it's nice to see. And there's been good papers on this that like sort of just break it down for you. And it's such a cheap tool, you know, it's just a dermatoscope. So if you have it, try to use it. It's not something we automatically reflexively take out when we're looking at melasma. This is different from ochronosis. So ochronosis is this like pigment deposition disorder, usually from tainted hydroquinone, right? So if they're getting hydroquinone in some way, you know, and it's tainted usually with like a mercurial compound, right? So we know that sometimes these off-label medications are tainted with mercury, and it can really cause this pigmentary disorder. So we want to make sure we're not dealing with that. But that usually looks a bit more obvious. And then just a plug for reflectance confocal microscopy. Not saying that you need this tool to diagnose melasma or any pigmentary disorder, but it's cool to see where the pigment concentrates. And it's usually in these like follicular openings around hair follicles. So again, even things like if they're depilating or they're using like hair removal thing, you know, they really need to be gentle with their skin because it can sort of induce and inflame and then lead to pigmentation. And there's been nice studies on that as well. So back to our patient, you can see it's just really interesting because there's intervening areas of normal skin. And then that's her confocal. But I want to get to the cases. So for treatment, for when I'm thinking about it, I always say combination therapy is needed. It's not like a one and done modality. There's really no standardized approach. So I think, like all of us said, you come up with your own approach and then you try to stick to it because it's the best way that you can have some evidence to back up your approach. Sun protection is probably one of the most important. So I always choose a physical blocker, and then depending on their skin tone, if they can find a tint that helps because of the iron oxide, then that's helpful. But obviously the tint has to match their skin tone, and that's like one of the hardest things in commercially available tinted formulations. But a mineral blocker, zinc or titanium dioxide as your base is probably the best compared to the chemical sunscreens because those can also irritate the skin. You want to definitely address the exacerbating factors, so oral contraceptive use, heat, any other sort of, if they have a thyroid issue, it's good to get those addressed early. And then, you know, I like what Dr. Watchmaker said, we call them brightening agents. We don't necessarily call them whitening agents because you don't want to say the word, you're not trying to whiten someone's skin, right? Because that's counterproductive. We're just trying to go back to their baseline pigmentation. And then I start with a series of superficial chemical peels. I rarely have to use this oral, but are you using it, Nolani? Yeah, right?
I use it a lot.
Yeah. So Nolani should talk about this because more and more people are using it. I tend to just find something with topical, but we can address that. And then laser, I usually build up the superficial chemical peels to medium depth chemical peels. And then lastly, I will add on a laser. Rarely microneedling. But again, UVA, UVB, and visible light, iron oxide in the tint. Oral protection is limited for use in melasma, but I do sometimes, if these patients are super highly motivated, this oral polypodium leucotomus, it's a fern extract. It just boosts your endogenous UVB protection. But there is some evidence in that study that it also increases your UVA protection, even though it may have not been statistically significant. So there's a UVA and UVB protection. They have to take it daily. There's no lasting effect. But if they're super highly motivated and they live in a super sunny location, it's interesting. And then consider switching birth controls, right? So if this is an exacerbating factor, you may want to consider partnering with their, PCP to switch these. Progesterone only or hormone-free contraception may be better than your traditional OCPs. And again, any photosensitizing medications. I've had patients on blood pressure medications that was extremely photosensitizing, and that was like one of their triggers. So we already went through all this. Azelaic acid is a nice add-on. These are just topicals. And then let me get to the cases. And then the topical tranexamic acid, it's available. So not only is it thought to inhibit melanin synthesis, but it also reduces vascularity. And I think that's where your vascular component comes in. So going back to just looking at the tissue and seeing if there is a vascular component is helpful. And so I would love to hear your thoughts at the end, Nolani. But there is a blood clot risk for tranexamic acid, so you do want to review any risk factors like smoking, history of blood clots, et cetera. Good. And so this is a patient who, for me, like she had classic, melasma. She probably has something that's also causing her to be photosensitive, but we couldn't really garner that from her history, but very classic. And this is through not only a series of chemical peels, but also topical therapy, obviously. So I always start them on hydroquinone, like we talked about, a retinoid, and a steroid, at least 4 weeks ahead of time, just to prime their skin. And then I usually start, for them, I usually start with a Jesner's peel, but I use Jesner's with resorcinol in it, not the modified Jesner's that doesn't have resorcinol. So I like the use of resorcinol. I know there are some people that think it's more irritating and can cause like hypopigmentation, but I haven't seen it. What are your thoughts on that? Anyone?
I use modified. Yeah. I use the modified Jesner personally, but that's just what I've gotten comfortable with.
Yeah.
Same. I use the modified Jesner's, but I haven't tried the resorcinol.
So I just go straight for the regular Jesner's. And then for me, I can start with a Jesner's because I think it's a good place to start. They will get some sort of appeal, but then I will start to layer it on. So then eventually, after a few rounds of Jesner's peels, I'll go to Jesner's plus TCA, like a low dose TCA, even in darker phototypes.
How many passes of Jesner's are you doing?
So I usually do 2 passes, and it will get a little bit of a frost, yeah. But they won't get a crazy amount of peeling afterwards, especially if they're moisturizing at home. They won't see as much of a peeling. But then when we go to Jesner's plus TCA, they'll get more of a peel.
And do you
So I start low with the addition of the TCA, like a 10% TCA. But then I could work my way up, depending on how much also photo rejuvenation or how much like topical rejuvenation they want to get, yeah. But she got a pretty good result, though for her, I think that her melasma can come back at any moment's notice.
Do you think she has a vascular component too that isn't being fully addressed with the peel?
So yes, and I do think, but also the topicals, like we were talking about, really can irritate them, and it can bring out this erythema. Mm-hmm. So it's also something that we have to mitigate. Yeah. Mm-hmm. But yes, for that redness, I could use a vascular laser. Mm-hmm. But she got a good result, I would say. And then so in skin of, darker skin types, I think it's also important that we look at what else is going on. There was a scar here as well. And this is this is a laser that we were talking about, like with Dr. Hibbler, plus the topical bemodoprost. So you can repigment these scars. Again, you have to deal with the hyperpigmentation usually afterwards, but that's usually easier than the hypopigmentation. And she had a nice result.
And that was just with laser?
That was laser with the topical bemodoprost, but then I did do chemical peels for her whole entire face afterwards. So
you did the Jesner's?
Mm-hmm,
and you've never have any issues with like hyperpigmentation and skin of color with Jesner's?
Hyperpigment?
Yeah.
No, but they're always on topicals as well. So they're on a topical hydroquinone regimen, yeah.
What laser did you use, sir?
For that, I just used the ultra pulse it's the deep setting, so just to make the channels for the bemodoprost, but like very low density.
5%?
Yeah, and very low fluence. It's just literally to make those channels and then get them in. This is a patient with significant like dyspigmentation. I think this is a combination of medication-induced and melasma, But this is just a series of chemical peels. Again, starting with Jesner. I usually try to do the same thing each time, so I know in my head what's working and what's not. But this is Jesner's, straight with resorcinol, and then eventually building up to Jesner's TCA. But it does take a quite amount of sessions, like anywhere from like 3 to 6 sessions.
What interval of time?
I usually, so with the Jesner's TCA, I would wait longer, so at least 6 weeks in between. Yeah, because there's some downtime in there. And then this is another patient who's, quite severe, I would say. And I always, when I see this, I don't think of like regular melasma. I think there's something maybe in contact, like a contact dermatitis. So you always try to ask for things like anything else going on, if they're like scrubbing their skin, and causing like an irritation. Sometimes that happens. Sometimes we see this, with this black soap. I don't know what's in there, but sometimes like people use it and it can really cause an irritation. But she improved quite nicely, right? So it's lightened up, but you can still see there's some hypopigmentate, and those were probably there. And again, there's like this erythema that I think happens after the peels and after the topicals that we can then address with either a laser or just sometimes calming their skin down with a low dose topical steroid.
Do you ever do the Jesner with the TCA off face, like on the legs?
Jesner's, yes, but for that I would go a very low dose TCA.
Like at 10%?
10%, yeah, just because the legs I do use it, but they're slower to heal. The face just heals much better.
And is there a body surface area maximum that you do off face? Like, would you do like just their calves or just like their upper back?
Because of systemic absorption, I haven't seen it, but with phenol, definitely, like you can only do segmental peels, but with TCA, I haven't had anything. Should I?
I don't do people's entire, both legs at the same time. I'll do like their lower legs.
I'll do both of their legs, not like up to the groin, but I'll
Yeah.
do like the shins, and front and back, yeah. I know it's 10, yeah.
Do you have any? Are you
No, we should, yeah.
Oh, all right, well, thank you. I know we ran over the time here. I think we had some really good discussion. Thank you to everyone who stayed.